The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, it's Donna here again. I hope that you've all managed to log in okay and that the sound's okay. Once again, thank you so much for your time in tuning in for the second one. I know that it's usually your lunch break and stuff, so I just really appreciate that you're taking the time out of your day. So today we're going to be looking at a nurse-led clinic or a nurse-initiated clinic and how I've done that with other clinics that we've worked with. So here we go. So the objective for today is similar or exactly the same as last week, and it's just simply to consider what's possible in your own workplace. I know, like I said yesterday or last week, that not all clinics are the same, and so there's no one set way that's going to work for everyone. So it's taking out the bits that you think will work for your place and then seeing where you can take it. Any questions, just chuck them in the questions box as we go along, or if you have any other questions or any other information that you want, feel free to email me at donna@cdprogramdevelopment.com.au. So recap from last week. In any clinic or primary healthcare organisation, lots of patients, lots of need. So it comes down to who do you want to see, what do you want to do with them, where do you want to see them, when do you want to see them, or how many can you see, why are we doing this, or what's the point, and then how do we make this financially viable. So a case study for today. Now this is a medical centre that we're currently working with in South Australia. It's in a rural location. There's 11 GPs, which equates to a 7 full-time equivalent. There's one nurse who's dedicated to chronic disease management for 4 days a week. They use best practice as their clinical software, and they have the PenCat data extraction tool. So for them, the first question is, who do we want to see or who do we want to target? So the first question to ask was, who are our patient population? So we used Pen computer systems. Now I know I've had some emails from some of you talking about the PenCat tool, and I've also had questions about the Canning tool. Pen computer systems is one that is largely used. The more people in WA I found use Canning, but I think Pen computer systems is coming to its own. And I had a look at the Western Australia Primary Health Alliance, and I think they're supporting the PenCat or the Pen Computer Systems tool for clinics. Now, Pen Computer Systems had a significant update in July of last year. So I'm not sure how many of you are familiar with PenCat or have used it, but there's a whole chronic disease module that you can use now in Pen Computer Systems. They have recipes for all sorts of different data outcomes. So there'll be a recipe for identifying patients who may benefit from a home medication review. So if you go onto their website, and I have the link there, and you go to their recipes, it'll have a step-by-step instruction as to how to get these reports. So for instance, the home medication review, you'll end up with a list of patients who may benefit from a home medication review. And they have lots of recipes for all sorts of different things. But there are compatibility issues with Pen computer systems. For instance, from my understanding that it's not working well or at all with Genie software program. It does work with Communicare, which I think is primarily an Aboriginal Health Service clinical software package. It ideally works with Best Practice and Medical Director, and it also works with ZMed and some other ones in WA. So we could do a whole hour on just how to use PenCat, but it really comes down to the software package that you're using and the compatibility with that. My suggestion would be to contact WA Primary Health Alliance to see if they have a license that you can use or if they have training and updates that they can use for you as well. But they are both available. In the event that you don't have a data extraction tool like PenCat or the Canning tool, you are able to still data extract from your medical software. Again, I haven't worked a lot with Genie. I've certainly worked a lot with Medical Director, Best Practice, and ZMed. Their functionality differs across the board for all three of them. Some have very detailed reports. Some, just have really detailed medication reports. So it's really going to depend on what medical software you're using as to what you can get out of it. But you certainly can use them to get some data out. So data searching, either through something like PenCat or Canning or through your medical software, you can usually search by disease state or a medication. Example, with diabetes, you might be looking under type 1 diabetes, type 2 diabetes, the whole NIDM and IDM, which I know isn't popular, it's not used anymore, but you'll still find some clinics or some old school GPs who will still code patients as NIDM and IDM patients. There might be just plain diabetes or gestational diabetes. So when you do a data search in your clinical software, you may have to select all the different types of diabetes to get the patients out. I often get asked by clinics, how can we make our GPs code properly? If I had an answer for that, that would be brilliant, but there is no answer except for trying to tell the GPs, please code your type 1 diabetic as type 1 or your type 2 as type 2. Don't use NIDM and IDM. But again, it comes down to the GPs and their willingness to code properly. I know it's an issue, and it's an issue with every practice I've worked in, the whole argument over coding and GPs. Now, a tip here for searching by medication. With this practice that I'm working with in South Australia, for example, our COPD patients, what we did is we put in COPD in PenCat or even in the clinical software, and we got a list of patients who were coded with COPD or chronic obstructive pulmonary disease. And what we did out of interest then was did a medication search for patients who are on Spiriva and Onbrez, and there was a difference in the lists. So there were more patients on Spiriva or Onbrez than there were patients coded with COPD. So again, it comes down to a data entry and a coding problem where the patient may have been prescribed Spiriva or Onbrez specifically for the COPD, but they've never been coded as having COPD. So my tip would be when you're searching for diseases like COPD or osteoporosis will be to do a disease state search, then try a medication search. And often there's a discrepancy. So there'll be patients that are taking a medication who aren't coded, or those who are coded but aren't taking medications. So it's worth having a look and seeing what the GPs are up to. So at this medical centre in South Australia, so using PenCat and practice software, we identified their patients, who are their patient population. So they have just over 5,000 active patients. So an active patient, according to most clinical software and PenCat, is that the patient must have been 3 times in the last 2 years. So it certainly, on the most part, excludes holidaymakers who may have visited once, came in because they stood on something at the beach, had a tetanus shot, and they've never been back. So you really want to get that down to your active patient population. So these are patients who are more likely to be your actual population and not holidaymakers or the transient population. We also discovered that they had 331 diabetic patients, 855 musculoskeletal, 541 asthma, which is always a big number, 283 cardiovascular disease, and only 65 COPD. Just for interest, we did a data search on their medications, and I think they had about 80 patients on COPD medications. So again, there's that difference of patients who were prescribed the medication but aren't coded with the disease state. Things like osteoporosis and COPD, that's easy to identify because it's unlikely, extremely unlikely, that you'll be prescribed Spiriva if you don't have COPD. And likewise, you're unlikely to be prescribed a bisphosphonate if you're not osteoporotic. So they're two disease states that the medication goes hand in hand with the disease state. Where something like aspirin, could be prescribed for a range of different things, whereas COPD medications are for COPD and your osteoporotic ones are for your osteoporosis patients. So who do we see and who do we target? So we found out who their patient population were at a glance. So we had to look at what was impacting their community or their region. Now, this clinic is in a farming region and in a big wine region in South Australia. Certain times of the year, health just isn't a priority. There's a poor uptake of health assessments and care plans in this clinic. And vintage, during vintage, which is usually around February to April, is when they are harvesting all the fruit to make wine. So between February and April, everyone's in the vineyards working. So if you were to send out a recall letter or an invitation letter to this population around vintage time, the envelope's probably not going to be opened, let alone read, let alone actioned. So for this community, it's important for us to know that if we're going to be targeting our health assessment group or our 45-year-old working population, that we're going to get a poor uptake during vintage in this community. So who do we see and who do we target? So what are we good at? So with this clinic, we had to look at the GPs and the nurses to discover what is it they want to do. And the GPs had an interest in diabetes and the nurse had an interest in diabetes as well. And the clinic also identified that there was a financial incentive for them to do diabetes as a first initiative because they wanted to attract the practice incentive payment for their diabetes. So who do we see and who do we target? So the other question was, well, what is it that we want to achieve? What were they hoping to get out of looking at their diabetic patient population? They wanted to target their diabetic population and they wanted to be known in the community as a medical centre that had a diabetes clinic, that had a diabetic clinic, that it was a service that they could offer, that they were very good at, and that they were very targeted in approaching these patients. And they also wanted to achieve the target to receive the diabetes payment of 50% of all diabetic patients having had a diabetes cycle of care. Once that tips over the 50%, then the practice receives practice incentive payments, and they're about 30%. So they're quite a way off getting that practice incentive payment, and they wanted to increase that. So for this clinic, the next question was, well, what do we do with them? Now, being a smaller rural community, we had a look around and who were their local allied healthcare providers and what their wait times were and if there were gap payments. So there were 3 podiatrists in the town, and we knew that one of them wouldn't charge a gap. So there was no out-of-pocket costs for the patients to attend him to have their foot check. The other 2, there was a small gap. The other 2 had less wait times. So in consultation with the podiatrist, all the 3 of them, we had arranged that the podiatrist that was no gap, we would send our patients to who were more financial hardship. And the patients who are more likely to be able to afford a small gap, we referred to the other 2 podiatrists. We didn't want it to be seen that we were favouring any one allied health care provider in the community. And so we were quite open with them. This is what our plan was, and they were all quite happy with it. And we also opened up the conversation with them that if for whatever reason they were feeling overwhelmed with the referrals, that they would let us know, and we would just try and stagger those referrals or, see if we could send the patients with financial hardship to the others, if they need to be seen earlier. So it's very much an open dialogue with the podiatrists in the community. There's also the optometrist and a dietitian in the community. Now, the optometrist said that he would be happy to do team care arrangements, but only for patients with diabetes. So he wasn't interested in seeing a referral for optometrist care for a patient who wasn't diabetic. And that's his prerogative. We simply said, look, that's fine. Thank you for your feedback. So we can go from there. and the dietitian was just happy to see anyone. So what were we going to do with them? We wanted to have information for these patients about Diabetes Australia, Diabetes SA. And so another tip here is a lot of, when I walk into a lot of general practices and they have a chronic disease room, it's usually wall-to-wall brochures and pamphlets about everything, which is fantastic. But what you need to be mindful of is a lot of health information goes old really quickly. So it's fine to have, tips about looking after your feet or, other bits and pieces. But when it comes down to the relevant latest medication advice or other guidelines, I would really recommend directing patients or showing them or going to their websites. So, for instance, there's, Diabetes Australia or Osteoporosis Australia, the Heart and Lung Foundations. So you're actually going to these websites, it's current, it's the latest information. You can have a shortcut to their link to their website on your computer screen, so you can just go there quickly. And it also, if the patients, and most patients now have access to internet, and so what it does is you're also trying to incorporate that self-management. So when I do care plans with patients, I'll often say, oh, you want some information about calcium and vitamin D. Okay, well, let's go to Osteoporosis Australia. It's a reputable site. It's got great content. I'll show them through the website, go to the information on calcium or vitamin D for them. We might print off the information sheet for them, but then say, look, I'll write down that web address for you on the bottom of this piece of paper, because as you can see, there's information about exercise, or there's information about different milks or that kind of stuff. So it's just kind of getting patients into that habit of self-managing so they can actually access this information themselves, which is not a bad thing. So what did we want to do with them? Glucometers, availability and cost. We wanted to know what was around for our patients, what the chemist had, what the cost was, blood glucose level diaries. So again, we just contacted the pharmaceutical companies and said, can we have, your diaries? Can you send us some, please? And sharps containers. Often when you're talking to, especially your insulin dependent diabetics, they're handling sharps. And so often we'll ask them, what do you do with your sharps containers? And often, or that your sharps, and often they'll say, I chuck it in the bin. And we know that that's, it's not an appropriate way to handle their sharps. So we'll often say, well, it's probably a good idea to have a dedicated sharps container that you can put your sharps in. But then they're going to be the question of, well, where do I get one? So in this small community, they've got a small rural hospital. So we liaised with the hospital and said, if we were to get sharps containers from you, can the patients come in and pick it up, or can we have some, and can I deliver them back to you when they're full? So how they're going to manage their sharps. And another tip here is Abbott Pharmaceutical will often have free glucometers, the Freedom glucometers that they will supply to clinics that you can give away. And what you need to do is just fill in the warranty card, show them how to use it, and then either send the warranty cards back into the pharmaceutical company, or they'll come and collect them depending on where you are. But they'll provide you with as many free glucometers as you need. I don't work for Abbott Pharmaceutical at all, but it's a fantastic service. So, and I've set up some clinics with these in WA and SA. So, Abbott's Pharmaceutical. The benefit for Abbott's, of course, is that when you get your test strips, you get a script for those to go to the chemist, and you actually, they benefit by the test strips. But for people that are, that can't afford to race out and buy glucometers, or if they're visiting diabetes educators once every 3 months, it's a good stopgap to be able to get them up and running with a glucometer. So where do we see them? So this clinic in South Australia, the nurse is available 4 days a week, and she has 6 one-hour appointments per day. She has 3 in the morning, has a lunch break, and has 3 in the afternoon. She has hour-long appointments, and they have the use of a dedicated chronic disease management room, but they only have that available for 4 days. Now, I know some clinics will say an hour for an appointment is very generous, or it's very long. She'll find that sometimes she'll only take half an hour or 45 minutes to do a review of a care plan, with that extra time, that's when she does the recall letters, or follows up with some allied healthcare providers, or does some data mining through her software. So she may not always use the full hour, but what she doesn't have then is a make-up time at the end of the day. So some clinics will have nurses working all through the day and then have an hour at the end of the afternoon to catch up. So she doesn't have any catch-up time, but how she uses that hour is pretty much up to her. And that's what they've decided works in that clinic for them. So when do we see them, and how many can we see? So at capacity, this clinic can see 24 patients per week through the nurse for chronic disease management. And we know through our data search that we had 331 diabetic patients. Now, 331 was a big number to send out 331 letters all at once for our diabetic patients, knowing that at capacity they could see 24 a week. So what we did is we looked at those who had a HbA1c of greater than 9. Now with PenCats, you can pull out that kind of data and you can break it down by, percentage of HbA1c. Another clinic I'm working with doesn't have PenCat, and what they did is they actually contacted the pathology lab and got the pathology lab to send them a report of their HbA1c results, which was doable. I think it took about a week, and they got a report back from the pathology provider that said each patient and the breakdown of their HbA1c percentage. So it's possible to do it that way. So we decided that with 24 patients per week, would send out letters to our 54 patients with a HbA1c of greater than 9% first. Now, we said that they had a capacity of 24 patients per week, but they were already seeing patients for care plans. It was a very reactionary approach to how they did it, but she was already doing some work. So we didn't want, it's not like we're wanting to fill up 24 patients a week straight up. So that's why we limited the number of letters we sent out. So after we sent out our 54 letters, and got a reply from them, then we followed up with the HbA1c of between 8 and 9%, and then we followed up with the HbA1c of between 7 and 8, and then our HbA1c of less than 7%. Now, another tip here, we found that patients with a HbA1c of less than 7, these patients here, if you had an HbA1c of 6.2%, which is pretty good, sometimes these patients were diet and exercise controlled. They were newly diagnosed diabetics, or they had been really well maintained. So sending out an invitation to these patients, they felt less urgency to come in, because they looked at themselves and said, look, I'm pretty well. My diabetes is well managed. A lot of them would say, well, I'm only slightly diabetic, or I'm not really diabetic, I'm just a little bit diabetic. Because they kind of looked at themselves as very well managed and quite okay. So for these letters, we could afford to send out 100 letters at once because the uptake wasn't as fantastic as with the first 54 that we sent out, who, if you're a HbA1c of 9, then you're likely to be on insulin and a more unwell, more unstable diabetes. So you tend to get a better uptake from those guys. Now the other tip here is when we send out letters, either for chronic disease management or health assessments, or even if it's a pap smear recall or immunisation recall, with the chronic disease and health promotion ones, we usually send the invitation letter out on blue paper, or pale yellow, or pale pink, whatever makes you happy. And what we did then is, say if we sent out 100 letters and all of a sudden people were calling in, the receptionist would tend to get a bit cranky with all these phone calls coming in, and often it was people who would say, I got a letter, I don't know what it's about, something about me needing an appointment. So then the receptionist would have to try and decipher or get out of the patient what the letter was for. Often they didn't have the letter with them, or they never read it. So what we would do was we'd send out all our recall letters on blue paper for chronic disease management and health promotion. So if a patient rang reception and said, hi, I've got a letter here, something about me needing an appointment, the reception staff simply said, was it on blue paper? And the patient goes, yep. Reception then knew that means I need to make an hour appointment with the nurse, followed up with the GP. And that's all the receptionists needed to know to make an appointment. So all their blue letters were for an hour with the nurse, followed up with 15 minutes by the GP. I think their pap smear letters were on pink. And so if the patient rang up and said, I've got a recall letter, it's for, I think it's for a pap smear. I think it's what it's for. The receptionist just simply said, is it on pink paper? Yep, fantastic. And so they would book appropriately. So it makes the booking process a lot easier for reception staff, and it just makes it that you're getting a lot less phone messages to ring people back because they don't know why they're ringing in the first place. So just another tip there. So why are we doing this, and what's the point? So like we said last week, the point is to improve the patient outcome, to increase the nurse role in general practice or in another primary healthcare organisation. There's also the financial benefits. So this is the slides from last week. I'll go over this because it's pretty important. But there is improved patient outcomes. So there are clinical indicators. There's also improved medication compliance, improved understanding of their disease state, and an ability to self-manage. And that's where, directing patients to reputable sites, the Better Health Channel, Diabetes Australia. So you're getting them to look up information that's specific to them. It's always really important that they're engaged in their process. That they can take some ownership, that they're not left doing everything for them. So it certainly increases the nurse role in general practice. So there's an increased leadership, a proactive role in patient management, and the development of policies and procedures to improve patient management. So the nurse setting up nurse-led clinics or nurse-initiated clinics is that you have some ownership over this patient management. I don't know if I said last week that when I was employed at the clinic that I used to work at, I was employed as Donna. I was the chronic disease nurse. And I left there 2 years later as Donna, the clinical coordinator for chronic disease management. And so it was really, I really formed a role or a responsibility at that clinic to really take on the ownership and the management of this chronic disease program, and built that position and built that role. And then I left there. On your resume, you're able to say that yes, I've run nurse-initiated or nurse-led clinics. I've been in control of these patient management strategies. I've coordinated these programs. It's all stuff that goes into your tool belt to when you move on, and that's really important to take those opportunities, because it's never just a nurse in general practice, or I'm just a nurse in primary healthcare. It's a pretty important role, and a role that we don't put enough emphasis or wealth of information on, but it's certainly there. And financial benefits. So there's also the financial benefits of a chronic disease program in the clinic. There's increased revenue through Medicare billings for the participating GPs, as well as the ownership of a clinic. And there's the ability to build a business model for future initiatives. So this clinic in South Australia, the nurse working 4 days a week, that's the only time that they have the room availability at the clinic. So what she's decided is to go to the ownership team and say, look, we've got a chronic disease program that's working really well. We can see that the increase in patient numbers, better uptake on recalls. So she's gone now and said, with our over 75s, I'd like to be able to do more at-home visits, and I'd like to do it on that 5th day. So on that 5th day where I don't have a room availability, can I take that day as an extra day working and do over 75s in the home? So that's only just started that in the last couple of months, and it's working really well. So for her, she wanted an extra day's work. There was the patient population to support it, and now she's able to go to them and say, well, here's a business model to support me having an extra day's work. So that's worked for her. Now, the financial benefits for care planning. So I'm not sure if you're familiar with the actual revenue attached to the item numbers, but a new care plan for a patient, which is just a 721, which is the care plan, and a 723, which is the team care arrangement, is a total MBS billing of $258.55. Now, a review of a care plan, which is 732 times 2 if you're reviewing both the care plan and the team care arrangement, plus the nurse support item number of 10997 is $156.10. Now, there's additional item numbers that we can, initiate. And again, it's depending on your clinic and what the setup is. But there's an ECG, there's spirometry, Doppler, and diabetes cycle of care. So extra item numbers that you can, in consultation with the ownership or the GPs. But these are items or services that nurses most times can initiate. So at this clinic in South Australia, they like to have a baseline ECG on record for their chronic disease patients. So they like to have an ECG on record every 12 months. And we explain it to patients that you've come in today, had a care plan, we've done an ECG for you. And they say, oh, I'm not having any chest pain, or what's that for? We say it means that we've got one on record. So in a month or 2 months' time, if you were to come in and say, look, I had a bit of chest pain, I think it was just indigestion, but it was just this niggly chest pain, we can do another ECG at that point in time, and we can have one to compare. So you can compare your new ECG with that baseline ECG. Now, again, not all clinics do that or support that, but it's up to you to, you can go back to the ownership team or the GPs and say, look, is this something that you would support? Some clinics say we want a baseline ECG just for our cardiac patients, or whatever the case may be. Now, spirometry, this clinic also supports if a patient comes in and they have a history of smoking, or they're a current smoker, to at least have one ECG on record. After that, it's the GP to decide if they want more. And this is mainly for a patient who's not asthmatic or COPD. So this might be a diabetic patient who's a smoker, or a diabetic patient who's had a history of smoking. The nurse is able to initiate a spirometry for that patient. Doppler, they're fortunate enough to have a Doppler machine. So for their diabetic patients and for their vascular disease patients, the nurse can initiate doing a Doppler in a care plan appointment or in a review if you've got the time. And often it's the nurse which is the best positioned to know when the diabetes cycle of care is due to be billed. So what the nurse will often do is highlight these item numbers that they've done and pass that information on to the GP for the GP to bill. Sometimes the GP will have a look and for whatever reason say, look, I don't want to bill the diabetes cycle of care. I'm not sure that I want to bill it, or that I've done all the requirements, so they'll keep that item number off. Ultimately, it's always up for the GP to decide what they want to bill at a consultation time, because they're the ones that are responsible or accountable to Medicare. So as a nurse, sometimes it's frustrating. I can do all this work. I can provide those item numbers to the GP and they'll forget some or drop some off. But ultimately, it's a GP's decision. And you just got to sometimes let it go with that. But there's no reason why in an hour's appointment, if you had an hour, that you could do a care plan, and within that care plan do a baseline ECG or a spirometry within that hour, or a Doppler. Often when I've seen diabetic patients and that's for a new care plan, I might be flat out during that hour just getting them, their head around being newly diagnosed diabetic, that I simply haven't had the time to do an ECG or a spirometry or a Doppler. Because for me, that priority during that appointment has just been talking to them about their diabetes. And because none of those things are urgent, I've put a note in the record saying to the GP, I'll do an ECG next time they come in. It's not urgent, but I just didn't have the time, to stop talking about their foot care or their eye care to give them an ECG. So again, it's something that you can discuss or negotiate with the ownership and the GPs. But again, the more that we can initiate and use our clinical judgment, I think the better in primary healthcare. So the financial benefits. So if one diabetic patient was seen over 2 years and had their initial care plan plus a review every 4 months, which is 5 reviews, plus their nurse review numbers, that 10997, they could have 5 of those a year, so that's 10 over the 2 years, plus 2 ECGs, 1 each year, that's $1,152.25 per patient. And so if only a quarter of our diabetic patients in the clinic attended, that would be 95,000 or just over 95,000 over the 2 years, just in those 82 patients. And those 82 patients have come in, they've had time with the nurse, they've had regular reviews, plus or minus ECG, whatever it may be. So you can see that the numbers add up really quickly with care planning. Just a note here, when, again, like I said last week, I'm happy to admit my faux pas and failures over the years. When I was working at this clinic and I'd become the clinical coordinator, I thought I was due for a pay rise. And I worked out the figures, and I said, for my 6 days, I'm bringing in this much money, and that's a lot. So I went to the general manager and I said, oh, look, I think I'm doing a bang-up job. I'm seeing all these patients. I'm generating all this income. Say it was $200 per patient, and there was 6 a day, and times that over by the week. I said, well, I'm generating for you X amount of dollars, so I want a pay rise. And he lovingly sat me down and said, look, do you know how general practice works or primary healthcare? I said, no, I just, I think I'm due for more money, thanks. And he said, in general practice, it's a privately owned clinic. And so the GPs there will generally take, say, 75% of their billings, and 25% of the billings go to the company, to the organisation, to the general practice. He said, so for every, $100 you think you're earning us, 75 of that goes to the GP and $25 goes into the bank. He said, so from that $25 per patient, I have to pay for the electricity and the phones and the biscuits and the tea and the coffee and the toilet paper and whatever else, the consumables out in the treatment room. So I learned pretty quickly that if I was going to go to the ownership or to the GPs with a business model, I really had to look at how much money am I generating and how much money actually goes to the general practice into their bank account. And it's a far different story than what I had walked in with and then to one that I walked out with. So yes, you can look at $1,152 over 2 years or the $95,000 for the 82 patients and go, I've made that much money. You've made that much or helped generate that much for the GPs that are participating. Maybe a quarter of that goes into the general practices or the primary healthcare organisation's bank. So it's just important to keep that in the back of your mind, because a lot of nurses that I speak with in general practice will look at that 95 and go, I've made that, and so surely I can have my fair share. But typically it's not how it works in general practice. It's something to keep in mind. I learned that lesson pretty hard. So that there are financial benefits. So what then? So with this clinic in South Australia, so we had gone through our process of what did the patients, who were they, what did we want to achieve, what was the outcome. We did all that with our diabetes patients. And then we sat there and looked at our musculoskeletal, our asthma, cardiovascular disease, and COPD. And you're absolutely right in saying that a diabetic patient may also have asthma, cardiovascular disease, and musculoskeletal. So there's lots of comorbidities. So what we did then is we looked at our musculoskeletal, and 855 is a massive number. You certainly wouldn't send out 855 blue letters for your all of these patients. So what we did is we looked at and said, well, what is musculoskeletal? Because in that comes arthritis, your rheumatoid arthritis. I think your osteoporosis coming under that with PenCat. So I was taking that big number of 855 and making that down into the smaller numbers. So with this clinic, we're looking at our rheumatoid arthritic patients. What's that number? What's our number of arthritis patients? And really breaking that big number, 855, down to a smaller number that we can send out those letters to. And same with asthma. Now, asthma is 541, and I think I mentioned last week that asthma may have been a patient who came in, and got prescribed Ventolin once, and the GP coded them as of having asthma, but it was a one-off kind of episode. And so to send out 541 blue letters to all your asthma patients is going to be time-consuming and a little bit soul-destroying because you won't get a great return. So then what we did with asthma is who of our asthmatic patients is on a preventer plus a reliever, and then a preventer plus reliever plus prednisolone, just to take that big number down into a smaller number. Because bearing in mind, we've only got 24 patients a week, and we've already got our diabetic patients who are coming back regularly for their reviews. So who else can we put in now with our asthma patients? Cardiovascular disease is very big and very vague as to what cardiovascular disease actually means or what's the breakdown for that. So again, with cardiovascular disease, we looked at our patients who are on warfarin and said, okay, let's target our warfarin patients first. We think that they're really care plan worthy. We want them to be able to be aware of the dietary limitations, not too many leafy greens or alternative medications. We wanted them looked at. So we dropped that big number down to just our warfarin patients. And again, with COPD, it was like, who are our COPD patients and what's happening with those guys and getting them in. So the tip there is just to look at these big numbers and how can I make that big number small? Because 855 seems, well, to me, it's a big number and it's quite daunting to send out 855 letters. So what do I need to do to make that a smaller number? Now, if that means that your patient who's just on Ventolin, who's, well managed, hasn't had any troubles with their asthma, does that mean that they're less worthy of a care plan? No, certainly not. And if they could benefit from a care plan, that's fantastic. But given the time and the resources that you have available, who are you going to see and who's in most need? So again, it's, taking those big numbers and making them small and making them an impactful number of patients that you can see. So then another tip here is to look at these disease states. And I know as nurses, we like to fix everyone all of the time, straight away, now, done. But chronic disease management is just that. These are chronic conditions, chronic diseases. These patients are going to have diabetes forever. They're always going to have their COPD or warfarin. So for whatever reason, these patients are chronically ill. So what we do is we look at diabetes. We might look at diabetes for 2 months or for 3 months. So for 3 months, we've done our data search. We've identified our patients. We've got our HbA1c breakdown. We've sent out our letters. We're doing our recalls. We're tidying up our database. We're looking at our care plan. So we're really tidying up that disease state. Then after 2 months or 3 months, we kind of go, stop. We park diabetes. Now, in the meantime, the patients who are already been seen or on recall are going to keep coming back. So that's great. But what we do then is we move our focus to musculoskeletal. So then we go, okay, well, let's look at our rheumatoid arthritis patients. Let's identify who they are. Let's get them in. Let's look at our care plan for arthritis. Is it a good care plan? Does it need to be fixing up? Do we need to tidy up the data entry or a recall process for that? We might look at that for 2 months. Then after that 2-month period, we stop. Then we look at asthma. So then what you do is over a 12-month period of time, you move through diabetes, rheumatoid arthritis or arthritis. You might go through your asthma. You might go through your warfarin. Then you go through your COPD. And the following year, you can repeat that. And so what you do is over a 12-month period of time, you're looking at a whole bunch of different patient populations. You're looking at patients with diabetes, heart disease, COPD in a coordinated, targeted way. And what you're doing is you're giving each disease state a good look, a good going over. And then say the following year you go back to diabetes, you might do the same data search again. You might go, okay, well, look at who's over 9 now. And you might have a different group who are over 9. You might have some newly diagnosed. So it's not that you're ever going to run out of work to do. It's like, okay, well, let's look at our diabetic patients now and really see what's happening with them 12 months on. And that's where you can look at and see, well, have there been improvements? Or watching a patient over 12 months or 2 years, what's their HbA1c figures looking like? So you can really track what you're doing and what's the point. Have we made a significant inroads into these disease states? So over a 12-month period of time, you've built up a chronic disease calendar. You're looking at different diseases, different patient populations, and at the same time, you can be upskilling yourself on different disease states. So you're learning a bit more about COPD, about cardiovascular disease, about asthma, about rheumatoid arthritis. And then you can really get exciting with it, and you can tie in health assessments to these. So with your diabetes initiative, you might say, look, we're going to look at diabetes, but what can we attach to that as a health assessment? So let's look at those who are at risk of developing diabetes. So there's a whole health assessment for that. So let's look at our 40 to 49-year-old patients who are at risk of developing diabetes. So again, if you've got something like PenCat or Canning, there's probably a recipe for those patients. But if not, you can data select who are our patients who are 49 years old, who have an increased waist, who have high cholesterol, or have had an impaired glucose in the past. So you can data extract the patients who you know are at risk and send out invitation letters to those patients with an OSDRISK quiz in there. So they're going to fill in this quiz at home and go, geez, I am at risk, and come in for a health assessment. And then you might do rheumatoid arthritis or osteoporosis and go, you know what, let's attach to that our over 75s. The osteoporosis kind of that typically affects an older population. So when we do osteoporosis, attach to that our over 75s. So let's send out some over 75 letters. Let's target those guys. And you could do your over 75s again with your cardiovascular disease. You might do some more 45 to 49-year-old health checks when you do asthma, like more of a younger population. So let's attach that health assessment. So what you're doing is you're looking at different health assessment categories. You're targeting different patient populations that ties in with your chronic disease calendar. And often what you can do, and I think we spoke about it briefly last week, is tie these in when it's National Diabetes Day or National Heart Day. Tie in these initiatives with what's happening nationally and try and take advantage of the advertising that's on TV and attach it to your chronic disease program. Now, there were quite a few emails about what a template looks like, because I spoke about last week of our diabetes template. So I've got this here as well. Now, with templates, there's a couple of requirements that are necessary, like they need to have a patient consent, a planned review date, what the template's for, the patient's name, the GP's name, and all of that's pretty standard on any care plan, usually the first page. Where these ones differ, and I apologise if that's too small, but that'll be on the handouts as well, that these templates that we've designed are designed to use for 2 years. So you can see here that these columns coming down, there's an initial care plan, then a review at 4 months, 8, and so on. And so what these are designed to be is that you newly diagnosed or a new diabetic care plan for someone, you pull up this care plan and you go to the initial care plan and you date it. Then you're working down the column, you fill in the squares. Now you'll notice that some of the squares are shaded, a slightly different colour, and those shaded squares are the diabetes cycle of care. Now some clinical software will have a separate form that you can fill in, and a lot of GP clinics fail to bill a diabetes cycle of care because they're just not quite sure they've got everything done for it, or they can't find all the bits and pieces that make up the diabetes cycle of care. So what this template has is all of the components of the cycle of care in the one template. And if you're going across the top again, when the patient comes in for their review, you open up the same document. So it'll be 4 months ago in their correspondence out or in their letters, whatever clinical software you're using. If you reopen that document and you add to it, so you add your 4-month review, and then you save it as a new document and it gets saved. And then the 8-month review, you open it back up and you add to it. And what it does, if you can imagine, is when the patient comes in for their first time and you've recorded their HbA1c in the box, and it might be 9.2, because we have targeted our HbA1c of greater than 9. We've got a 9.2 HbA1c there. Give them some information, their medication's reviewed, they've put on extra medication, or they've started their exercise and different intake of food, they come back in 4 months and their HbA1c might have dropped to 8.7. So now you've got HbA1c of 9.2 and then 8.7. So it becomes a visual stimulant for patients. So they see this document, and it's a living document. It's seeing their results over a period of time. And it worked really well with cholesterol medication, because often patients will, for whatever reason, might stop taking their cholesterol medication. So they come in and you go, look, your cholesterol was 4.6 and now it's 5.2. They go, oh, yeah, I stopped taking it. And you go, look, that's okay. You talk about medications, a GP puts them on it. They come back at that 8-month mark and their total cholesterol might be 4.7. And it's that visual. You can see how it was okay. Then it got high, recommenced that medication, it's gone back low. So it becomes like it kind of affirms their behaviour. So if they stop taking a medication, they can see the consequence. It's not a one-off result that gets lost. It's in this document that compares it visit to visit along the way. And again, designed to be used for 2 years. So the shaded boxes are the diabetes cycle of care. And you've got them there, you just fill them in. And then we've got nerves. So the first page, my apologies. So HbA1c, blood glucose level, blood pressure, cholesterol. So pretty stock standard stuff at this point in time. The nerve damage. Now the column here with the podiatrist, optometrist, ophthalmologist, they can be used as the team care arrangement. So you can tick your little box and say for the nerve damage, yes, referred to podiatrist for comprehensive diabetic foot check. Podiatrist to see this patient. They might come back in the next time and you go, did you see the podiatrist? Yeah, I saw them, that's great. I'm seeing them every 10 weeks. So in that 4-month column, it's like, has seen the podiatrist, has had a foot check, is on 10 weekly reviews. So it becomes a story of this patient's care over a 2-year period of time. So then there's eye damage. Now, some of these diabetes cycle of care are once a year, every 6 months. So if you get to the 12-month mark on the columns and all your graded, if you look back in the previous columns and all your grey boxes are filled in, that you've written something in all of them, then you can claim your diabetes cycle of care. That simple. So you don't need to be going out and gathering all this information. So you might have in the kidney damage, you might have their eGFR and the microalbumin results in there. So it's done. So you don't have to go back into pathology and go, well, have we done a wee? Have we done this? It's there because you've got the recorded result in there. So here we've also added in sexual dysfunction and obstructive sleep apnea. So things to ask these patients. Consider I think it's Epworth Sleepiness Scale. So we have that on a link. So they can just ask these questions of these patients. Physical activity, weight and waste, nutrition, smoking, alcohol. Again, all components of the diabetes cycle of care. Immunisation status, ambulance cover. Do they have ambulance cover? Do they have a medical alert bracelet? Self-care education is a diabetes cycle of care, but one that often GPs or nurses, if they're not on a really good structured care plan, it's difficult to find evidence of self-care education. So here it can be, yes, we've referred them to a diabetes SA or diabetes educator. There's some group sessions. You can write in, have discussed diabetes, given them the website for, Diabetes WA. So again, you've got this recorded, easy to locate proof of a diabetes cycle of care. Medication review. Do they need a HMR? Glucose. Do they have the glycagon kit? And if they do have that little, that orange needle in that packet, are they familiar with how to use it? Does their family know how to use it? I often say to patients, it's great that you know, but in the event that you need it, you're probably not going to be aware that you need it. So does your family know? And if that expires, have your family practice with it, take it out, feel it, and use it, and before you get the prescription for the new one. So just those practical tips for patients. A couple of extra boxes for goodness knows what. There might be something that you think is pertinent to put on their care plan. So you can just add it into the bottom. In the bottom section of it has their allied healthcare providers. So I might say that, yes, I might tick the physio. That's the name of the physio. And I might just put their contact phone number. And then say at the end of that appointment, if we've referred them off, go, well, there's the name and the contact person of who we referred you to. So, however you do it in your clinic, go home, give them a call, make an appointment, or if that's who it is, but we'll make the appointment for you, depending on how it is. So it's a comprehensive care plan used for 2 years for that patient. Often they'll say that they'll keep it and they'll take it to their specialist appointment, into hospital, whatever the case may be, but it's all their recorded diabetes specific information on there for that one. So nurse initiated clinics. The intention, the key to making any initiative viable is intention. So nurse-led clinics or nurse-initiated clinics for really good operating chronic disease programs don't happen on their own. It's a deliberate and intentional patient management strategy. And you've got to be deliberate in who we target and how we target them and what we do with them. So these things don't happen by accident. It's intention and it's deliberate. The clinic that I was working with, our percentage for our diabetes incentive payments was at 96%. So 96% of our diabetic patients had a diabetes cycle of care every 12 months, because it was just very intentional and very deliberate as to how we managed our diabetic patients, and it's very achievable. So I think that's it from me. What I'm hoping is that you leave after today and last week with just getting an idea of what's possible. What can I do with my patient population? What is it I want to achieve? What is it we're good at? And who are our patients? And what's possible? And just to make those deliberate plans. Speak to your GPs and the allied healthcare providers and get them on board. How many can you see? Is there a gap? What's the best time that you'll see them? So you set your patients up for success. You're getting your allied healthcare providers on board. There's an open communication. We've even negotiated with our allied healthcare providers for them to waive the gap, because we're doing a diabetes initiative. So would you waive the gap on these patients? Or anything's possible when you're just intentional and deliberate about what you're trying to do. So I sincerely hope last week and this week has just given you some idea of what's possible or what you can do with chronic disease management. Any questions or anything, please feel free to give me an email and I'll return them as soon as possible. And happy to help in any way at all to see what's possible in your own clinic. Thank you so much for listening, and I really appreciate it. Thank you.